And next we will have the talk by our Chief Instructor, Dr. Jyothi Anup from Eye Vision Eye Hospitals, Thrissur. She is a senior phaco surgeon and phaco and refractive surgeon. And I congratulate her for this wonderful course. The interesting hand-picked topics and covering the entire area of the spectacle-free world. And Dr. Jyothi will be talking about phakic lenses to correct the refractive errors. And her caption is phakic IOLs, not just an alternative. Over to you, dear.
Good evening all. My topic for today is phakic IOL, no longer just an alternative. I'll be talking on implantable contact lenses. Usually, they work like internal contact lenses, usually done for individuals more than 20 years and done in moderate to severe myopia. Ideally done who are not the candidates for LASIK or surface ablation. And it can correct astigmatism up to 6 diopter. And ICLs definitely give better visual clarity, better contrast and no glare compared to LASIK or surface ablation. And it is a reversible procedure. And the only demerit is it is an intraocular procedure, and so we have to do one eye at a time. And the first FDA approved US company is Star Surgical, which is there in the market from 2005. And there are Indian make phakic lenses also. The Star ICL is made up of collamer, and the Indian make phakic lenses are made with different material. They are hydrophilic acrylic material. Each company has got different names. Icryl by Biotech, refractive implantable lens by Apasami, and IPCL by K Group. And a thorough preoperative evaluation is mandatory as of any refractive surgery, along with the workup for other laser procedures. We have to measure the anterior chamber depth also. Anterior chamber depth should be more than 2.8 or more. Ideally, to begin with, it is better to select patient with ACD 3 or more. And a white to white measurement is mandatory, which has to be more than 10.8, and it has to be done by the surgeon itself. Also, you can measure the sulcus to sulcus and angle to angle measurement also. They are all measured by ASOCT or UBM, but you need high technical skill, and which is not always possible with the technician. And if you have a specular, it is ideal to measure and the specular endothelial count also. And the loading of star ICLs, that needs some practice, and it is a bit cumbersome also. This is how you load the ICL. You have to inject visco and BSS, inspect the lens for any manufacturing defects, and with the cotton tip, they provide only one lens at a time, so you have to be careful while handling the lens. If you put it down, then that is it. And you have to pull with this special forceps, which is provided with the thing. You have to buy it, and ideally you have to pull the cartridge, then the lens will come forward. And here, this ICL loading needs some practice. You get dummy lenses to practice. And before making the corneal incision, it is ideal to load the lens. As what happened here, this lens got stuck with the foot plate got stuck with the haptic. And in such situation, you have to keep it open, and like you have to multiple times you have to open and close the forceps, and I am pulling it down and up and down, and somehow I got it with this. So it is always better to load the lens, keep it in the BSS to avoid drying, then you place the corneal incision. And implanting ICL is not that difficult for a person who does topical phaco, but care should be taken not to injure the anterior capsule while making entry. You have to have a very slow injection, and before the final push, you have to wait till the foot pedals, till the foot plates spreads out. And the tucking the foot plate is also another that with a particular, with the peculiar movement you have to put it in. And washing the visco after IOL implantation is a must. And while before implanting the ICL, the injecting visco, you have to be careful not to overinflate the AC. That will float the ICL and make your implantation under the iris difficult. So you have to don't overfill the AC with the visco. And here what happened? Here I had a problem while injecting the ICL. I removed the cartridge before the trailing haptic was in. So these lenses are very thin. While injecting, any manipulations can damage the lens or torn the foot. Your foot plates can be torn. Luckily, I got it with this. And usually the implantation of the ICL take less than 5 minutes, but washing you have to take out all the entire visco, especially from the central pot. Otherwise, you may get a postoperative IOP hike. And this is a Indian made, this is a biotech ICL called ICRIL. There is no problem of loading. This loading is like any other IOLs. So beginner can always practice with an Indian ICL. Once you are comfortable implanting the ICLs, then you can shift to the other one. And toric ICL is also available. Usually you don't have to rotate it. Most of the time it is aligned in the 180 degree itself. And I insist the loading of ICL needs some practice, and washing all the visco is crucial. We do give post-operative acetazolamide for 2 days, as sometimes you may expect some IOP elevation post-operatively. And ideally you have to measure the volt. It should be, the ideal volt is 500. It should be between 250 and 700 microns. If it is a very low volt, the patient can get cataract. And if it is too anterior, patient may develop glaucoma or even corneal damage. Thank you.
Thank you, Dr. Jyothi, for that very lucid presentation. And you have touched upon everything in ICL. And ICL surgery appears simple, but you have the preoperative assessment, as she was telling, and the postoperative yearly OCT, yearly vaulting measurements, and assessment of cataract.